Hi, Nicole here from Nurse Manager HQ. This week we're going to cover off key performance indicators. It's one of those major areas where I think it shakes fear into the hearts of most new nurse managers, as it's not something that we often are exposed to, give much thought to, and seems something that's at the hardcore end of the business continuum, as opposed to the other end where we normally sit, which is about care delivery and looking after the patients. So this is something that seems a long, long way removed from our normal everyday core business and practice. But there are some couple of interesting facts about key performance indicators that we're going to talk about so that we can demystify those. We're clinicians. We're always going to be clinicians, even if we're the CEO of a major corporation that delivers some sort of health service delivery. We are still, at our core, nurses. And if you ask any nurse what it is that they want to achieve, the answer is generally going to be the same. And it's going to be something like the best patient care for those who need it, when they need it. Really, if it's just about excellent care in a timely manner for all Australians, really. And your community may not be all Australians, it might be for all patients in the North Adelaide district who need a total joint replacement and need orthopaedic surgery, or it might be in remote New South Wales for all patients who are pregnant or have just had a baby. So your community might change, but your excellent care and your timeliness and for all of the people that you can deliver care to doesn't change. If we were going to rework those into key deliverables that might be measurable, then what nurses are after are outcomes, access and equity. That's it. We want to deliver great care when people need it, everyone directly in our community. I go through this part of it intentionally because when you're going to measure anything, you want to quantify the deliverables. And when new nurse managers come to this role, they often look forward to that hardcore business end of the continuum when they sit at the other end of the very hardcore care end, and it seems like it's stuff that they don't know anything about. It's business and it's money and it's drivers and it's profit and loss statements and it's all of this stuff that I don't know about. But really what anyone is measuring in a hospital is the same thing that you are. The CEO is measuring the same thing that you as a nurse is measuring: outcomes, access and equity. And we just frame them up differently to the other end of that continuum. That's all. We say great patient care for everybody when they need it. They say outcomes, access and equity. So it really doesn't change. But what's important is, as a clinician, you've made a promise. When you applied for the job, a nursing role, it might have been a role as a registered nurse and it might have been a role as a CEO. But when you applied for that job and you got interviewed, you made a promise that you could deliver what the job said that you could deliver. And that is great patient care to everybody in your community. So let's take a ward, for example, when they need it. So you were going to assess that they needed care, you were going to deliver it, and you were going to give it the same care you gave to the patient on Tuesday the 31st of October as you were going to give to someone on Christmas Day, as you're going to give on another random date in the 1st of April. It is going to be the same care every single day, and you made that promise when you took on that job and you take the pay for it every single week. It's only right that there are people around that measure that and ask the question, are you delivering what you promised? And take a step up from that, is your health service delivering what it promised? If you are working in rural New South Wales and delivering care to your community, which is pregnant women and postnatal women in that community that don't have access to tertiary referral hospitals that we find in the city, are you delivering that? You made the promise that you could. Can you do it? Are you doing it? There's a lot of money invested in paying for you and your team and the resources, both human and material, to support that health service delivery. everybody's got someone to account to, whether it's the shareholder or whether it's the government of the day, and the question is asked, are you delivering? And that's what key performance indicators are all about, and that's what we're going to go through, the nitty gritty of what exactly a KPI. I hope to demystify what a KPI is, and realise that you've actually been using them every single day of your life. You're just going to change the numbers behind them. Okay, so let's have a talk about key performance indicators and at their core what they are. A KPI offers insight into effectiveness and efficiency of a particular program, and that's what we've just been talking about. You've made the promise that you can deliver care to this group. Now there's someone saying, are you doing it effectively and are you doing it efficiently? If it takes an inordinate amount of money to deliver care to the rural and remote, and that money could be better spent elsewhere, and that test of contestability is applied. Is this the best use of the money that we have, providing care to the rural and remote anti and postnatal women of rural New South Wales? Then you have that question to answer, and you need to make sure your answer is always, yes, it's effective. Yes, we're delivering the care to those when they need it, and for the right group of people, and we're doing it efficiently. So after all, what gets measured gets managed, and that's a really important thing to understand. If people are looking at numbers, then anomalies are going to fly out. It's going to be obvious, and you can have the opportunity to correct that. And that's what's really important to understand about. It's not just a punitive thing. It's not just someone sitting in an ivory tower looking at this and making snap decisions. That can be part of it when it is out of control, but actually the little incremental things and anomalies that crop up along the way get managed and mitigated at the time, so that you're never in a situation where the ultimate question is, are you effective? Are you efficient? I don't think so. We're going to have to shut the servers down. It allows nurse managers to answer questions. Quantifying care can be really, really difficult. To say how you deliver care, why you deliver care, and why it's important can be really difficult for nurses to articulate, because so much of what we do as nurses is intangible. And so with the help of key performance indicators, when you have a structured scientific approach, it gives you the opportunity to provide advice on the appropriateness of the care and the program, the successes, the shortcomings, and the future directions. If you were to write that in a narrative, it would be really difficult to sell that concept succinctly and easily so that people would understand. If you were to sell it in a narrative, it would be full of jargon and full of contextual concepts that the layperson wouldn't understand. Whereas when you translate it into key performance indicators, it's understandable whether you're a clinician or you're not. So it's an incredible vehicle for nurse managers to be able to articulate what you do, how you do it, what's great, what's not, where you need help, where you don't, and where you need future directions to head. That gives entities the opportunity to be responsive to that community that you're providing care. It gives them the opportunity to be efficient, and it gives them the opportunity to be accountable. And when I use the term entity, then I might be referring to the government. I might be referring for a profit organisation that is accountable to shareholders, and I might be referring to a not-for-profit organisation. But in the end, they are accountable to someone. The government's accountable to voters, and the profit sector is accountable to their shareholders, and the not-for-profits are accountable to those to which they've promised social accountability to. And they want to ask questions, and I think it's fair that they do. Also, these entities, government, the profit sector and the not-for-profit sector, got into this gig because they wanted to achieve something. And they want to be responsible to their community. Clearly the government want to be responsive to their voters. That's in their interest. Clearly the profit sector want to be responsive to their shareholders, and their shareholders expect them to deliver excellent care. And the not-for-profit community clearly want to be responsive to their charitable body they represent. But they all have limited amounts of money. Sometimes it's a gargantuan amount of money that they have, but it's limited. And they want to make sure that they're always pass contestability. That is this the best use of the money at the time? They've made this play, they've committed to this program. There are a lot of programs that they said no to, and that's the important thing to remember. Whenever these entities make a choice to fund something, they're also making a choice not to fund something else. And they want to make sure at all times they've made the right choice. So it's up to you. You made the promise you could. So it's up to you to be able to stand up and go, yep, you've made the right choice. This is how we can prove it. It gives the opportunity for the entity to track and report trends as well, so that they can make decisions about the program's ability to achieve what their claimed objective is. So really this is the thumbs up, thumbs down moment. What gets measured gets managed, and as anomalies crop up over time, then they can address them. But when trends crop up over time, when over the last 12 months not once have you met budget, over the last 12 months your material resources key performance indicators have ramped every single month 25% off, 25% on, another 25% on, then those trends drive an ultimate decision, and they have to make a decision. And they also have to make a decision about tracking opportunities as well. If you are finding that you are really, really nailing your promise and your KPIs are just, you're thumping them in, then that trend gives an indication there may be an opportunity to expand the service and include more of your community when they need it for the program objectives for which you set out to achieve. So those trends are important so that you can do more or less with whatever it is that you are achieving to do. This also promotes the opportunity for accountability by allowing genuine comparisons and benchmarking. There are a lot of service deliveries that are exactly the same countrywide. There are a lot of post-operative surgical units in this country. There are a lot of orthopaedic wards in this country. There are a lot of ICUs. There are a lot of obstetric units. There are a lot of community health service delivery that are providing in-home care, that are providing mothercraft services. There are a lot of like services in this industry. And for an organisation that needs to be accountable, then they need to be able to say, well, we do it for this much per patient. How much do you do it for? We're a lot more than that. And you need to have an understanding of why that is. And it gives an opportunity to drill down and find why it's an anomaly. Some of them will just be simply because of your case mix are more complex and the socioeconomic drivers are such that the costs are more. And sometimes it's you have to provide the service, but there aren't that many patients. So it's hard to be incredibly efficient when you've got 10 patients as opposed to the downtown Sydney organisation that can flood 100 people a day through. So there are some times that you can justify it, but overall, when you're comparing apples with apples, you need to know that this Orthopaedic Queensland unit is the exact same as the Perth one, because there should be really no differences. So it's a great opportunity for accountability and benchmarking. So this part of the section is all about, so you've said you can give great care. Excellent. Are you? And more importantly, how do you know? So you say yes, but how do you know? And that's what the KPI in essence seeks to do, to prove or not prove in a way, in a language, in a standardised language that everybody can understand, everybody can compare, and you can have a good hard look at the promises that you've made. So now we need to start looking at the anatomy of a KPI. And for the most part, any KPI that is used should be what we know as a SMART KPI. Now the same framework for SMART can be said for goals. When you set a goal, then it should meet the SMART criteria, and the same can be said for a KPI when you structure it. So when we talk about SMART, we mean S for specific. Does it focus on the results directly related to progress? You have to be specific about, well, is this directly related? Measured, is it quantifiable in units or targets that can be compared over time? Is it achievable? Is this KPI realistic for the related performance currently and the resources available? Is it relevant? You have to link program objectives with the respective effectiveness of the KPI. And timed. Is it time framed for completion, or is there a time that's related to it? There's no point comparing. Ever since we opened, we had, X number of patients. You need to measure that month on month. And there's a great example. Now, one of the most common KPIs in the acute care sector is how nursing hours per patient day. When we look at that, it is simply a ratio of the number of nursing hours per patient on a ward in any given day. And so when you look at it about that KPI and measure it against the SMART criteria, then you can say, is it specific? Does it focus on the results directly related to the progress? Yes. So we're looking at how many nursing hours does it cost to look after an orthopaedic patient that has just had a total knee replacement. And it will track your progress. Is it measurable? Yes, it's certainly quantifiable. We're talking about nursing hours. We're talking about number of patients at midnight. And it can be compared over time. You can compare your work hours per day, and you can have a look at your work hours per patient day over the month, and you can track it even over the year. So it's incredibly measurable and it's incredibly comparable. Is it achievable? Many would argue that their specific HPPD for their wards may or may not be achievable, and that's where you have to have a look at your ratio. So if work hours per patient day is simply the number of working hours per patient. So if you have a target HPPD for an orthopaedic ward of 5, then what you're saying is every single patient on that ward gets 5 hours per day of nursing care. So when you shower them, you mobilise them, you give them medications, you come and take their OBS, you monitor their wound, you set up their reinfusion drain, you give them some blood, whatever it is that that patient needs, it needs to be done in 5 hours, and every single patient is given 5 hours on that ward. Clearly, the 7-day post-op is going to need much less as opposed to the immediately post-op, but as a averaged ratio, 5 hours. If your HPPD for that orthopaedic ward was 10 hours, I would argue that is incredibly realistic and incredibly achievable. But if your hours were 2, could you genuinely look after 30 orthopaedic patients by giving each one only 2 hours of care every single day? I'd hazard a guess to say that most of you are saying no. So that's where you have to make sure that your HPPD or whatever KPI that we're talking about is achievable. Is it relevant? So if we're looking at nursing hours and we're looking at patients at midnight, that is relevant. But when you have a look at, say, an emergency department and you've got nursing hours, tick, but patients at midnight, well, no matter what ED that you're looking at, then the patients at midnight isn't really a fair indication of the number of patients that you've had over the course of the day. So a 15 acute bay plus 2 resus emergency department might have 5 patients at midnight. So we're going to make the ratio divided by in the denominator 5, and all of the patient care of the 70 patients that have been through, then that needs to be related to that 5. It's not particularly relevant. You could use the number of patients in the hospital, but that's not particularly relevant to the emergency department either. The fact that the hospital's full and have had a truckload of emergency cases and booked elective procedures has got absolutely nothing to do with the activity in an emergency department. So on the terms of relevance, then that KPI, work hours per patient day, is not relevant to an emergency department, but it's very relevant to a ward. And finally, timed. If you're going to look at work hours per patient day, then it's all about each day, and you track it over time, and you can track it month on, year on year. So HPPD for the use on an orthopaedic post-operative ward is a SMART KPI. And so you need to have a look and lay that on every KPI that you look at and make sure that it is a SMART KPI. The other thing that it needs to have is clear definitions, and relied upon their definitions industry-wide. Otherwise, the target is a bit messy and you're not really comparing apples with apples. A very classic example of that is the KPI work hours per operating minute. So that KPI is exactly the same. It's a ratio of the number of hours per patient, except that the denominator is not number of patients at midnight. It's actually the number of operating minutes that you've had all day. So if you've had 40 cases and you've done some TURPs and cystoscopies and a total joint and a craniotomy and the caesarean section and a list of cystoscopies in another theatre, then you add up all of the operating minutes for that day, and that becomes your denominator. So it meets the SMART criteria, and it's very relevant. Where the work hours per patient day wasn't relevant for the emergency department, work hours per operating minute has been tweaked to make it relevant for the operating theatre. So it meets the SMART criteria. The trick is, what is the definition of an operating minute? And that's where things have historically become a little messy. Most operating theatres in this country might include that the clock starts ticking from the time knife to skin until dressing's on. So all of those times, so while we open up the patient, perform the surgery, suture them up, clean them up, put the dressing on, the clock stops ticking. So all of those minutes are included in your KPI, and they're collated from the data, and that's what's used for the work hours per operating minute calculation and that ratio for that KPI. But there are some facilities that might count an operating minute from the time that the anaesthetist intubates until the patient leaves the operating theatre. So now we haven't got a clear definition, and we've got some hospitals using anaesthetic time to recovery in, and other hospitals using knife to skin to dressings on. There could be 30 minutes in that difference. Might be using a junior anaesthetist who's having trouble working out what's the best way to anaesthetise this patient, and takes a couple of attempts to put the spinal anaesthetic in. Or at the end, the patient hasn't woken up very well, and so we've kept them in the operating theatre until they can maintain their saturations at an acceptable level. So all of a sudden you've added 30 minutes, maybe an hour. And now the nephrectomy that did take X number of minutes and exactly the same in hospital A and hospital B, but the anaesthetic time's been included, and now one's an hour longer. And so now you're not comparing apples with apples. So it's really important to be clear on your definitions about what you're counting. When you're counting work hours per patient day, what nursing hours are you including? The nurse unit manager? Are you including the orderly? Are you including sick leave? Are you including annual leave? Offline time for the level 2 who's been given offline time to do the roster? You have to be really, really clear on when you say nursing hours, what's included. When you say patient day, are we talking about all the patients at midnight, or every patient that has passed through the department? So very, very clear definitions, and in making sure you understand those is important, because otherwise when you go benchmarking and your department is performing vastly differently and at very possibly much worse than others, that you'll walk away and you think, oh my God, how do they do it with that KPI? But you didn't ask what their definitions were, and all of a sudden you might have exposed the fact that they've included things that you don't, and that's your explanation. So being really, really clear on the definitions is a very important hallmark when you're dealing with KPIs. It's really the same with when you're measuring anything. When we look at research, when we were at university doing our undergrad or our postgrad qualifications, and when we look at research to include in our literature, then we want to make sure that that literature is peer reviewed, and the literature methodology that they used has certain hallmarks, and we are pretty familiar with those, that the tool that they used is valid, reliable and specific. And the exact same thing applies to KPIs. You want to make sure that they're valid and they're reliable, that the same result can be achieved every single time, no matter where you do it in the country. The same result can be achieved, and then it's comparable. Now there are a couple of domains when we talk about KPIs in terms of specifically what you should be measuring. There's a couple of ways that you can think about them and what the KPIs might measure. So there's one school of thought that divides them up into structure, process and outcome. Structure being the human material resources that is required to meet the community needs, including infrastructure. So what structures are required? Are you measuring what structures? When you say, yes, I can deliver excellent patient care that's effective and efficient, then one of those categories you need to look at is structure, the human and material resources to meet KPIs. You need to look at processes. What is done by the users? How will it be done? And how will it be compliant with evidence-based or with consumer expectations? So what are you actually doing? It's not just throwing nurses and medical supplies at delivering patient care. It's about how you go about doing it. What exactly do you do to deliver care to the rural and remote antenatal and postnatal patients in New South Wales if you're in that health service? How do you actually look after your orthopaedic patients when they come back from theatre and they land in your orthopaedic post-op ward to make sure that their care is the best that you promised that it was going to be? And the other part is looking at the outcomes. What is the state of health of your community that you promised to look after? What's their quality of life? What's their pain? Morbidity and mortality indicators. What's their level of knowledge? What are you going to measure in terms of the outcomes? And what's important here, you're starting to get a sense that these KPIs are not just about measuring the efficiency in terms of dollars. It's not just working out how much we spend. KPIs are not about money. They're about qualitative and quantitative measures. And this is the research that you've been exposed to since the first day in your undergraduate nursing degree. It's about quality of life, pain, morbidity, mortality, knowledge. How are you going to measure the outcomes? You say you're going to give great care. What are the outcomes that your patients walk away with, that they were better off having been exposed to you or your health service or your program than if they weren't? The other methodology that you can look at are another 5 key domains. Was the program that you delivered to your population safe, effective, person-centred, equitable and efficient? So safety, does it protect the health and welfare of your users or your patients? Was it effective? Did it deliver the best achievable outcome for the community that you sought to deliver care to? Person-centred, does it centre on the needs and rights of them, respect their values, preferences, and actively involve them? That's something that's really, really starting to take shape in our landscape at the moment in terms of actively involving the end user and the patient and the consumer. Have you actively involved them? You've gone off and done the research about what they need, but maybe they'd like to have some input into how their population and their community is cared for. Is it equitable? Does it provide fair access to everybody? And is it efficient? Does it use the best uses of available resources that it possibly can? So that's about contestability. Is this the best use of the resources that you have at this particular time? So as we move forward in really drilling down further and further on what KPIs, they're the sorts of things that we are starting to consider. It's not just about dollars per patient day. It's not just about measuring the money. It's not just for accountants. You are measuring every single aspect of what you do for your patient from the time they turn up and enter your program till they leave it. Then you need to be measuring every aspect of it. And you can chunk it up into either the structure, processes and outcomes, or you can chunk it up into a safe, effective, person-centred, equitable and efficient. But it doesn't really matter, provided that you are measuring both qualitative and quantitative measures so that you can get a fair picture of what you're doing. And that gives you the opportunity to, then they start to become usable. They start to actually have a place and not just the end of month report that you crack off and job done. There's something that can be used incredibly well, effectively and tangibly in everything that you do. Because after all, it's really about, are you nailing the target that you wanted to nail? You want to give great care. Every nurse does. And so let's see whether you nail that target. And so all those suites of KPIs that we just talked about, whether they're safe, effective, person-centred, equitable or efficient, or your suite of KPIs that measure your structure, your processes and your outcomes, however you want to chunk them up, but that suite of KPIs is known as your minimum data set to determine whether you've nailed your target. And that minimum data set is often packaged by organisations up into what's called a balanced scorecard. And it's really a scorecard to measure your performance, your promises, your care. Is it safe and is it effective? It's the suite of KPIs to say you're on track, you're off track. It's a suite of KPIs to identify where your opportunities for improvement are. The balanced scorecard is really something that is very, very popular in most organisations now, and it has been for a good decade or so now. What's starting to emerge now is the dashboard. That's really got some traction, and essentially all the dashboard is a graphical representation of your balanced scorecard. It's your suite of KPIs represented graphically, and you can see at a single glance where things are going well and where things are going haywire. And generally they're indicated by a traffic light system, so you can see where you're nailing it, where it's going okay or starting to get into a bit of tetchy territory, or where it's a mess and it's a red light. So you can see at one glance what's good, what's bad, and you can see the good, the bad and the ugly. It really seeks to flag great performance and poor performance. So it's something to action in the poor performance and something to celebrate with the good. What's incredible about this is that professionals have the most incredible sense of desire to correct things. That's what makes us professionals, is that we have an intrinsic trigger that when we see bad performance, then we need to fix it. You can see that every single day with nurses. When they see bad care, then they just can't leave it alone. They have to go and sort it. And that's actually what is one of the problems with nurses, in that they see a patient in trouble. They see a patient in a wet bed. They should wait for the orderly to come so that they can lift that patient they can use a no-lift technique. But they can't leave that patient alone. It's poor. To leave that patient in that bed would be poor performance. They just do it. They get in and they get it done because they have that intrinsic desire to sort it. And the same at this level in this context. When professionals see poor performance, they have an intrinsic desire, an innate trigger within them to fix it. And that's why some of these KPIs, while they're a hard sell to your broader clinical team sometimes, because they are something that's always associated with that other end of the continuum, with the business end, and it's not what we do. But if you are able to trigger that intrinsic desire in your professional registered nurses team to fix it, then you'll be able to deliver effectiveness and efficiency a lot easier. It is difficult. It requires incredible leadership. But it is a real opportunity to use these KPIs to feed back to your team and say, guys, every other orthopaedic unit can do this in and work hour of target of 5. We're 5.7. What's going on? Why can't we get this right? And get them, they'll have it's poor performance. If every single organisation is doing it and they can't, then it's reasonable to say the question, what's different about us? And they will trigger that intrinsic thing that sits inside every single professional to fix poor performance. What's important, it's not just you using these KPIs. There is a whole group of people that are using these KPIs. So it is an opportunity to engage your employees, and it should be something that you use for your employees. It should be something that you use to track your own performance and correct the poor and celebrate the good. And it is something that your direct line report will use to measure your direct performance as well. And they're all the usual people. But there's a greater body of people that use it as well. There is your advisory group, for example. Your advisory group is that person-centred consumer group that more and more hospitals are seeking, and it is a requirement in one aspect as well, to have a group of people that are representative of the garden variety case mix of your program delivery service, who can provide input. Now, having focus groups is not something that's terribly new, and there would often, particularly private hospitals, would use focus groups to give them advice about customer service, performance, whether they would use a new service or whatever. But your advisory group is not much more broad-reaching than that, because they want to know that it's not just nurses running this show, and it's not just the doctors running this show. It's not just the bean counters running this show. Consumers want to know that the care provided to their community is a well-balanced, well-orchestrated, well-oiled machine. And they have the objectivity, because they have no vested interest, they have the objectivity to sit on the sidelines looking in and say yes or no. A well-organised advisory group is designed to make sure that the right KPIs are chosen and ensure that those KPIs are fit for purpose. So it's your employees, it's you, it's your management team, it's your advisory group. But there's also a third party as well that comes along. And most of you will be familiar with this. ACHS come along every 3 years. And if it's not ACS, then it's another body doing the ISO standards. But your accreditation cycle is simply a third-party evaluation of your KPIs. It's nothing more, it's nothing less. So when you think about your accreditation cycle, there is a enormous body of work that goes in behind it. The actual survey is simply a third-party review of your KPIs. And if you haven't done that work, and you haven't done the quality in that 3 years, then you're not going to have many KPIs to show for it. Third-party review in your accreditation cycle is simply part self-assessment, part peer review. It is an external body that comes and certifies and monitors your performance. And it's a benchmarking opportunity and an opportunity for recognition. What it is not is regulation. Now, it might not feel that way, but they are actually not the regulators. They come along and undertake a peer review to see how you're tracking, because they are a body that reviews all organisations, all programs, all health service delivery. So they have some body of knowledge about being able to come and compare. And they give recommendations based on their knowledge and what they've seen compared with other organisations and how they've met those KPIs. So they give you feedback on where you sit benchmarking wise. And there are things that are mandatory in that, and so has a regulatory component, but essentially it is just a peer review of how your program is delivering to ask those questions about effectiveness and efficiency. That process gives you an alert and an opportunity for an improvement as well. So they come along and say, yeah, this hospital down the road is doing it in this way. I think you're well below where you really should be given the resources that you're throwing at it. Another third party that might review your KPIs are the regulatory bodies. So your State Department of Health will come and they will inspect infection control and your standards and your adherence to building codes, and private hospitals are subject to the State Department's private health regulatory unit coming and assessing any number of KPIs about the way in which you deliver healthcare. The complaints body for your state will come and review your quality processes and the way in which you assess and respond to your complaints. So that element of your KPI. Infection control groups will come along and inspect your KPIs in relation to how you travel with your infections and communicable diseases. So there is a raft of people that will come and third party and measure your KPIs as well. All of those processes are really about giving you ideas for improvement, and they signpost where you're sitting in regards to the 3 E's. At the end, there is just a matter of balancing 3 E's about every single KPI that you measure, and it signposts whether you're delivering your service in an economical manner, whether you're effective, and whether you're efficient. So there's a raft of KPIs that you need to collect so that you can measure against those. But to give you some of the others that I've given you, other than the work hours per patient day, work hours per operating minute that you might look at, then there are a great deal of other KPIs that you might well be used to. On a financial level, we'll also measure things like pharmacy per patient day. So your costs this month, what are the costs of the drugs that you've administered to your patient divided by the number of days in the month? So you're just going to get a simple ratio. It's cost us $39 a day per patient day to deliver medications to this patient group. Your pharmacies per patient day. How many patients have you cared for this month? Okay, how many days? You're just going to divide it up so that you get a number of $29 per patient day is what it has cost us to deliver medications to this patient. Then you're going to have a look at your medical supplies, exactly the same thing. So you're going to have a number for what it costs you. Now your number in a low acuity medical ward is going to be vastly different from a cath lab in terms of your medical supplies per day. But it doesn't matter. You're not comparing your performance with the medical ward. You're comparing your performance with cath labs. So if you can deliver the same range of services in the cath lab, angiograms and angioplasties, and you can do it for $500 per patient day, and down the road they can do it for $220, then it begs the question, how come? And that requires some investigation. That's what you do as a manager. That's your role. You manage your KPIs and your material resources according to where you could do better so that you can do more for less. You might measure some qualitative outcomes as well, such as falls per month, medication errors per month, complaints per month, compliments per month. Once you start tracking those every single month, you can see spikes, you can see trends, you can see decreases, deteriorations. There are lots of quality indicators that we're well familiar with in the research and that we can implement in terms of what we measure in our departments. Door to thrombolysis time, door to antibiotic time, for example, might be some. There are lots that are required in our accreditation cycle that are triggered. Returns to the operating theatre, unplanned admissions to ICU, readmits in 28 days. Your triage times, your CAT 1 seeing immediately. It's just a KPI. What's important to remember about these KPIs is that they can be proportional. So HPPD is simply a proportion or a ratio. How many hours per patient? My work hours per patient day is I can give 5 hours of care to every single patient every single day. Is that enough? Is that too much? It might be counts, number of readmits. It might be a sentinel event. They're not necessarily time-centred like in the SMART criteria, but they identify extremely poor performance. So a sentinel event might be deaths from medication errors. Where the data comes from for all of these KPIs, many and varied, but most commonly from your admin database. Hibiscus is a common one. So whatever your patient information system is, a great deal of the data from the KPIs is sourced from there. Same with the operating minutes. Your electronic operating room management system, and I know in Queensland Health uses Ormus a lot, those operating minutes are drawn from that. So when we talk about the accuracy of the definitions, you also have to think about the accuracy of the data and the integrity of the data. If you've got a whole load of scout nurses that couldn't care less about what time they put in, that has implications at a medico-legal level, but it also has implications in terms of measuring. So if they're swanning over and popping into the electronic operating room management system that the case started, 15 minutes before it actually started and 30 minutes after it finished, then that's going to radically change the way in which you appear to be performing, and that's an issue. So you have to be clear on your definitions and clear on the integrity of the data input. Well, it's also really important to engage your team in this process so that they do understand they're professionals, they have an innate trigger to correct poor performance, but only when they know about it. And if they have no idea that sauntering over and clicking the button 15 minutes early or 30 minutes late is impactful, they're never going to fix it for you. They have to have the knowledge to be able to be engaged in that process. So where the data comes from, admin databases, check the integrity of your data, check the definitions of your data that's going in there. Medical record. So you can go through your patient's medical record and get a whole load of information that formulates your KPIs from in there. Financial, your profit and loss, your number of your medical supplies and your human material resources will be prepped from the financial tables that your accountant, hospital accountant, will prepare monthly. Timekeeping, so Chronos, whatever timekeeping, whether it's a manual time card or whether it's a electronic time card, but that's a great source of information, particularly on the core KPI like HPPD. Then that comes straight off your time cards. Who worked yesterday? How many hours? Surveys, Press Ganey, Best Practice Australia, loads of data there to formulate your KPIs in terms of how you're tracking. And of course your equip projects. All of those projects that you've been doing in terms of the quality cycle so that you can improve performance, improve patient care, improve outcomes, improve effectiveness. Those are the things that need some level of data collection so that you can have a body of KPIs to measure against, so that you've got some evidence to put forward when you have your third-party review in your accreditation cycle. So that's KPIs, the demystification, I hope, of KPIs. They're not just financial, and they're not just for the accountants, and they're not just for the ivory tower to mull over every single month that have absolutely no implications on what you do in your core business. They're for a great many people, including the patient, your team, you, the surveyors from the accreditation, and of course the management team. But what they really should be doing is answering that question. You made a promise that you could give great patient care and make a difference for this community of patients that you've selected. Have you? Have you made a difference? And if you think you have, then you need to prove it. And that's what KPIs do. Hope this has helped, and I'll see you next time.